All right, thanks for having me, everybody. I'm excited to be here to teach about common HIV regimens and opportunistic infection prophylaxis. So a little bit about me and my background. I completed my first year general pharmacy residency training here at U of L and then decided to stay on and specialize in internal medicine. So I'm excited to work with you guys throughout the year and hope to see you as I move through all my rotations. I originally completed my bachelor's degree at Auburn University and my PharmD degree there as well. And my current professional interests include stroke, infectious diseases, and improving medication access. For our objectives for today, we'll be reviewing common HIV regimens. We'll discuss different patient and treatment different characteristics to help guide our therapy and selection. And then we'll also review and apply the Department of Health and Human Services guidelines on opportunistic infection prophylaxis in patients with HIV. So first, discussing our HIV treatments. This is a very broad and complex topic, but I really try to focus it towards things that you guys would be tested on for your board exams, and then things that would apply for taking care of patients with HIV in the inpatient setting. So first, I think it's interesting to take a look at how far we've come in our HIV care, all the way from when AIDS was first identified in the United States, all the way up until where we're at now, where we can control these patients' HIV, where they can live a normal lifespan similar to patients without HIV. So first, in 1981, this is when AIDS was first identified in the United States. It took us about 3 to 4 years to determine that HIV was the cause of AIDS. And then from there, about another year for us to develop a way to test patients. But at this time, we still didn't have a treatment option for these patients, so HIV was associated with a very high mortality rate this time. That was until about 1987 when our first antiretroviral therapy, or ART therapy as I'll call it from now on, zidovudine became FDA approved. This agent was associated with a lot of different toxicities which made it difficult for patients to take, and it also developed drug resistance very rapidly, so it quickly became ineffective in treating HIV alone. From there in 1990 we had our new combination therapy, so providers started combining our antiretroviral therapy. But again, they were associated with a very large pill burden, a lot of toxicities, which made it very hard for our patients to take it. Moving into about 1995 and 96, after the creation of our protease inhibitors, is where we really saw a change in our HIV care and our ART therapy. This is when the highly active antiretroviral therapy really started going out into the population, and our patients were able to prolong their life expectancy, however, not as close to a patient without HIV. As we've continued to streamline our care and create better ART regimens, we then moved into 2006 where we had our first single drug tablet regimen, ATRIPLA, came to the market, and this really just changed the care for our patients. It allowed them to take a single tablet with 3 different antiretroviral agents in it, and it was associated with a lot less toxicities and adverse events. So following our creation of ART therapy, we saw a dramatic decrease in our morbidity and mortality. As you can see in the graphic on the screen, HIV and AIDS deaths significantly declined following 2006 when we came up with these single tablet regimens. And this decline was even more pronounced in our Western and Central European countries and then North American countries. Not only did ART therapy help to decrease the morbidity and mortality in these patients, but it also helped to decrease the rate of transmission across our community. Moving into who should get antiretroviral therapy, ART therapy was originally thought to only be started in patients with a CD4 count of less than 500. However, with more recent studies, our guidelines now say that waiting for those patients for their CD4 count to drop below 500 can put them at risk for opportunistic infections and can actually delay their CD4 recovery. So now the guidelines recommend initiating ART therapy in all patients with HIV to help reduce that morbidity and mortality and reduce transmission. These patients require a very broad range of care and need to become established in a clinic. So that's why we typically don't see ART therapy initiated in the inpatient setting. These patients need to be seen by a provider frequently. They need to be educated on the disease state, the medications as a whole, and the importance of adherence, and be followed up regularly. So that's why we typically see them initiated in our outpatient clinics, like our 550 clinic here at U of L. But you may see them be started by our infectious disease team, but they will follow that patient outpatient, the 550 clinic after that. Looking at how to build a complete ART regimen, so like I discussed previously in our history, we've now been combining our 3 different ART therapies to create a complete regimen. So our 3 different drugs that are included are typically 2 nucleoside reverse transcriptase inhibitors, our NRTIs, and we call this the NRTI backbone. and then one of the 3 drug classes, either our integrase strand inhibitors, which are INSTIs, our non-nucleoside reverse transcriptase, our NRTIs, or our protease inhibitors. And typically these are given with a pharmacokinetic booster to help increase the amount of concentration in the blood. Protease inhibitors are associated with a lot of side effects, which we'll get into a little bit later, so they're typically reserved for last line or after INSTIs cannot be used. One important thing to remember with using our antiretroviral therapy is that you should never use monotherapy. This can create a lot of different drug resistance whenever we only use one therapy. So when you're initiating, you'll always want to make sure the patient's on a complete regimen. And then when you're reinitiating the patient's ART therapy inpatient, it's important that you reinitiate all different parts of their ART regimen. So if for some reason they can't take one part, you should just completely hold the complete regimen. And this is also something that our patients should be counseled on to make sure that they're adherent and we don't have any risk for resistance. So this slide just really gives you a brief overview of the HIV cell cycle and how it integrates into its host DNA and where all of the medications interact in this pathway. But we'll get into that with each of the different drug classes. But as you can see, when the HIV virus first fuses into the cell, this is where our fusion inhibitors typically act. They then go through reverse transcription, which is where our NRTIs and NNRTIs work. And then they are integrated into the host DNA through integration, and that's where our INSTIs work. And then they go through budding and maturation, and that's where our protease inhibitors typically work. So moving into our NRTIs, our nucleoside reverse transcriptase inhibitors. So like I said, this is going to be the backbone of most of our regimens. And our NRTIs include abacavir, emtricitabine, lamivudine, our tenofovir products, so tenofovir diproxyl fumarate, our TDF, and then tenofovir alafenamide, which is our TAF, and then zidovudine. Zidovudine is an older agent like I discussed previously, so it's typically not used in our patients because it has a lot of toxicities, but you could potentially see it, particularly in the OBGYN or gynecology department in patients that are pregnant and giving birth. So its place in therapy, like I said, is really the backbone of most of our regimens. It works by inhibiting reverse transcription by incorporating itself into the viral DNA. So that's why our older agents were associated with more toxicities like lipodystrophy, decrease in bone marrow density, and lactic acidosis, and hepatotoxicity. But our more common agents we use now, like our tenofovir products, are really well tolerated. The most common side effects are going to be like nausea, vomiting, diarrhea, skin rash, and some weight gain, but overall very well tolerated. When looking at drug interactions with this drug class, there's really not very many drug interactions. However, I will refer you all to the hivinfo.nih.gov website. They have a complete chart with all the different drug interactions through all the classes, and it's a great resource. And then also your pharmacists are a great resource just to make sure there's no drug interactions with any medications that we're starting in the inpatient side. Moving into our non-nucleoside reverse transcription inhibitors, our NNRTIs, that's going to be doravirine, efavirenz, etravirine, nevirapine, and rilpivirine. I tried to underline some certain ways that could help you remember which drug class it belongs in, so a lot of our NNRTIs end in virine. So our NNRTIs, their place in therapy, they are recommended for treatment-naive patients first line, but in special populations, so for patients that can't tolerate an INSTI or they have resistance to INSTIs. They work by binding directly to reverse transcription, so that's how they differ from NRTIs. So NRTIs incorporate themselves into the DNA, where NNRTIs bind directly to reverse transcriptase. So this was done to help prevent some of those side effects like the lipodystrophy that we saw with our previous NRTIs, our older ones. But they are still associated with some side effects like hepatotoxicity and skin rash, and you can even see more severe skin rashes like Stevens-Johnson syndrome and toxic epidermal necrolysis. One thing to remember about NNRTIs is that they do have many different drug reactions. They rely on the CYP450 pathway to be metabolized, which means that there's going to be a lot of different drug interactions. So if you see a patient on an NNRTI, it's always a good idea to run a drug interaction check and just make sure nothing that we've started interacts. So some specific ones that I just wanted to point out are like our anti-epileptics can interact frequently, and then our PPIs are particularly contraindicated with rilpivirine, which I know we start patients on PPIs a lot in the inpatient side. So it's just something that I wanted to point out that you may just want to check to make sure there's no interactions. Moving into our real workhorse, For our ART regimens, our Integrase Strand transfer inhibitors, our INSTIs, this is going to be bictegravir, dolutegravir, raltegravir, elvitegravir, and then cabotegravir. Our cabotegravir is going to be our IM injection. This is typically reserved for the outpatient setting because the patients need an oral lead-in when they take this regimen, and then they also have to meet certain criteria like being virally suppressed for at least 3 to 6 months. Our INSTIs, like I said, are first line for our treatment-naive patients when combined with our NRTI backbone. They work by blocking the catalytic activity of integrase, which is an enzyme that's needed for the HIV virus to incorporate into the host DNA. For class-wide side effects, they're again very well tolerated, which is why we use them a lot first line. The most common side effects are going to be diarrhea, nausea, some weight gain. You can also see insomnia with INSTIs, and then an elevated creatine kinase can be seen. It's pretty rare, but you can see it with raltegravir and dolutegravir. So I just want to point that out. For INSTIs, they really don't have very many drug interactions, but one that is important to remember is that it does interact with cation-containing products, so think like antacids, iron-containing products, or calcium. So if you're going to combine these, they need to be separated at least by 2 hours before or 6 hours after to make sure that we're getting our full treatment regimen and we're not interacting with any of our blood levels of our ART therapy. And then another drug interaction with these agents is particularly elvitegravir, which is combined with our boosting agent cobicistat. So cobicistat is going to increase our levels of our elvitegravir by boosting it, and it does this by the CYP pathway again. So there is a lot of drug interaction seen, particularly with this combination, but this combination is not really used as frequently in our most used antiretroviral treatment regimens. But it can interact with like our DOACs and other agents. Moving into our protease inhibitors, our PIs, this is going to be atazanavir, darunavir, and ritonavir, where ritonavir is mainly used as a boosting agent only. So if you see it in a treatment regimen, make sure to recognize that that's more of a booster agent and not necessarily an active ART therapy. Our protease inhibitors are again recommended first line similar to our NNRTIs, but mainly in patients that can't tolerate an INSTI or can't take an INSTI based off resistance patterns. It works by competitively inhibiting the enzyme protease, which allows the HIV virus to not mature, making it non-infectious. For class-wide side effects, it's not as well tolerated as, like, say, our INSTIs. It does have more nausea, vomiting, some diarrhea, lipodystrophy, and you can also see some metabolic side effects like insulin resistance and hyperglycemia, and then also hepatotoxicity. So that's why it's kind of reserved for patients that can't take INSTIs. And then again with our protease inhibitors, there's very many drug interactions. So it's always a good idea to check, but some common ones could be like our antiarrhythmics, like amiodarone, our DOACs, antiplatelets, and then our statins, particularly simvastatin and lovastatin, can't be combined with any protease inhibitors, but some of our other statins, like atorvastatin, may need to be dose adjusted. So referring to that hivinfo.nih.gov website can be really helpful with determining how you should proceed with using statins in patients with protease inhibitors. And then lastly, we have our entry inhibitors. This is going to be like maraviroc, enfuvirtide, fostemsavir, and our monoclonal antibody ipilimumab. So its place in therapy is really just for resistant HIV genotypes, so you won't see these as commonly, but I just wanted to point it out just in case you do see them. So how do you combine all of these different drug classes into one complete drug regimen? I wanted to briefly go through each of the recommended initial regimens that the Department of Health and Human Services recommends. So the first one is going to be bictegravir, tenofovir, alafenamide, and emtricitabine, which is Biktarvy. Our second one is dolutegravir, abacavir, and lamivudine, which is Triumec. Our third one is dolutegravir combined with either emtricitabine or lamivudine plus one of our tenofovir products. So typically this looks like Tivicay, which is dolutegravir, combined with either Truvada or Symduo. And then you can also see them use dolutegravir and lamivudine, which is Dovato. So this one's a little bit unique. As you can see, it only has 2 antiretroviral therapies within the regimen. However, we'll get into a little bit later on the studies that show that this 2-drug regimen combination was still effective. So moving first into our bictegravir, tenofovir, alafenamide, and emtricitabine, which is our Biktarvy. Some clinical pearls with this regimen is that it does have hepatitis B activity, particularly with our tenofovir, alafenamide, and emtricitabine. And we'll talk about this special population in patients that have hepatitis B and HIV co-infection a little bit later, but I just wanted to point out that this does have hepatitis B activity. It is not recommended for patients in a creatinine clearance of less than 30, and it does have a very high barrier to resistance, which is why we use it for our rapid start patients. And it's just one single tablet with 3 medications in that tablet, so the patient only has to take it once daily in 1 tablet, so it helps with patient adherence. Moving into Triumec, which is our dolutegravir, abacavir, and lamivudine. Some clinical pearls with this is that it should only be used in patients that are HLA-B5701 negative. This is because there's a lot of hypersensitivity reactions associated with patients that have this HLA-B5701 genotype, so they have to be tested before initiating this regimen or any abacavir-containing products. Some other things to consider is that it shouldn't be used with patients with chronic hepatitis B because they won't be completely treated with their hepatitis B, which can lead to flares and resistance. And like Biktarvy, it has a high barrier to resistance and a low pill burden, so it's great for our patients that have a hard time with adherence. Moving into our 2-drug regimens, so this isn't as easily administered as our Biktarvy or Triumec, but our combination of Tivicay with either Truvado or Symduo. It does have a higher pill burden, like I mentioned, so it may not be the best option for our patients that have adherence issues. But when picking between these agents, you can have a little bit more choice with which tenofovir product you use. So how you determine which one you use. The tenofovir alafenamide is typically preferred first line now because it's associated with less renal toxicity and bone marrow suppression as our tenofovir disoproxil fumarate. So typically you'll see patients using the TAF form of tenofovir instead of the TDF formulation. And then moving into our 2-drug regimen, Dovato, so that's going to be dolutegravir and lamivudine. It should only be used in a patients with an HIV RNA viral load of less than 500,000, and they shouldn't have a hepatitis B co-infection because it can cause severe exacerbations and resistance because we only have that lamivudine, which has some hepatitis B activity, but not enough to really treat our hepatitis B or keep it at bay. So when looking at how effective this 2-drug regimen is, this was proven in the Gemini 1 and Gemini 2 trial, which compared dolutegravir lamivudine to our dolutegravir intracitabine and tenofovir disoproxil fumarate. And they had about 1,400 ART-naive patients that had a baseline viral load of less than 500,000 and didn't have any hepatitis B co-infection. And they found that the 2-drug regimen was non-inferior to the 3-drug regimen in achieving an undetectable viral load, which is our goal with our ART therapy. And they also saw no treatment-emergent resistance mutations, so no mutations with using that 2-drug regimen, but they did see a lower rate of adverse effects, so this may be good for patients that can't tolerate our 3-drug regimens that contain like the tenofovir products. So now moving into our special populations, particularly our hepatitis B population. So in all patients before they get started on ART therapy, they should be tested for hepatitis B. If they have that Hep B surface antigen that's positive, they should have a viral load detected to see if they have active hepatitis B before initiating, and making sure that our patients are on agents that have some hepatitis B activity. So the guidelines prefer to use one of the tenofovir products plus either intracitabine or lamivudine, and they should be used in combination to make sure that our patients aren't going to be at risk for exacerbation or resistance. And then if patients can't tolerate that tenofovir, then the guidelines recommend using entecavir, which is going to be our hepatitis B treatment, with a fully 3-drug suppressive ART regimen. So that's for our hepatitis B co-infection. One important thing to remember in this patient population is that adherence is very, very important. So if our patients stop taking their medication, they can have reactivation, worsening of their hepatitis B. So it's really important that we make sure to get these patients restarted on their ART therapy as soon as we can, and then also counsel them on the importance of adherence. Moving into our patients with renal impairment. So this is kind of an overwhelming chart, but I tried to pick out some important pieces of our common regimens that you may see in how we can renally dose adjust these regimens. So for our Biktarvy and our Tivicay plus Descovy, the creatinine clearance cutoffs are really due to the tenofovir alafenamide and intracitabine portion of these regimens. So they're not recommended in a creatinine clearance of less than 30 if the patient's not on hemodialysis. but if they are on hemodialysis, we can use 1 tablet daily because it will be dialyzed. For our lamivudine-containing products like Triumec and Dovato, it's not recommended in a creatinine clearance of less than 30, but you can use the individual components of the regimen and just separate them. It will have the patient taking more tablets, but then you can dose adjust it to make sure they're on their complete regimen. And then for our tenofovir disproxil fumarate, so like I said previously, this form of tenofovir is associated with more renal toxicity, but they do have more data because it's an older agent on how we can dose adjust these products. So for our Truvada, it's contraindicated, or you would dose adjust in a creatinine clearance of 30 to 49 to 1 tablet every 48 hours. And then if their creatinine clearance is less than 30 or they're on hemodialysis, it's not recommended at all. And then for our Simduo, which is tenofovir disproxil and lamivudine, it's not recommended in a creatinine clearance of less than 50 or if the patient's on hemodialysis. So we can see a lot of our patients in the hospital can come in with an AKI or have worsening renal function while they're here. So it's important to just monitor this and see if they need any dose adjustments so we don't see more toxicities associated with our ART regimen. And then moving into our final special population we'll be talking about today, our pregnant patients. So how we treat our pregnant patients is really going to depend on where they're at in their ART therapy. So if they're already virologically suppressed on an ART regimen, they should be continued on that same regimen throughout their pregnancy unless there's significant toxicities associated with their regimen. So that would be agents like stavudine, didanazine. These are much older agents that we really don't see anymore, but it is just important to remember and double check all the different components of their regimen. If the patient's treatment naive and they find out that they're HIV positive while they're pregnant, the guidelines recommend using dolutegravir or raltegravir with an NRTI backbone. This is kind of interesting because previously dolutegravir was not recommended in pregnant patients. This data and recommendation really came from one Botswana study that showed a higher risk of neural tube defects in patients that took dolutegravir. But however, updated studies have found really no difference in the risk of neural tube defects in our dolutegravir-containing products versus other ART regimens. And we really don't see this concern in countries that have folate fortification in their food, like the United States, so it's not really much of a concern anymore. So that's why you'll see the guidelines recommending dolutegravir. They do specifically state that we should avoid bictegravir-containing products like Biktarvy, just because it's a newer agent and it hasn't really been studied in our pregnant patients. When moving into the intrapartum and postpartum period, this is really going to depend on what the patient's ART therapy is and their viral load at that time. If they're not virologically suppressed, we typically have to give them an IV ART therapy like fludarabine. So you will see this in our OBGYN and gynecology patients. If they're going to give birth and they have a detectable HIV viral load. Now moving into some of the newer ways to use our ART therapy, our PrEP and our PEP. So first, our pre-exposure prophylaxis or PrEP. This was previously indicated only in patients like men who have sex with men, but now they've really broadened that indication to any sexually active adults or adolescents that are at a significant risk for acquiring HIV. So this is going to be patients that have a partner that is HIV positive, someone who has multiple sexual partners where the HIV status is unknown, and then it's also recommended in persons who inject IV drugs that share, specifically those that share injection supplies, because that can put them at risk for acquiring HIV. So our two treatment options are Descovy or Truvada. So Truvada contains emtricitabine in our TDF product, where Descovy contains emtricitabine in our TAF products, or TAF. So how we decide which one we're going to use is based off who the patient is. So Truvada has been studied in women, so we can use it in all patients. With our TDF, it's a little bit older. Whereas for our Descovy, it's really only been studied in men or transgender women, so that's why the guidelines recommend only using this product in our men and transgender women. For our post-exposure prophylaxis, this is for typically healthcare providers that have an occupational exposure to HIV, so like a needle stick or exposure to blood in a patient that's HIV positive. For these patients, we should typically initiate this PEP within 72 hours and then have them continue their regimen for 28 days, with them being followed up and having HIV tests done throughout the way. These patients should receive a complete 3-drug regimen. So here at U of L, we actually have a policy and we supply people with PEP kits. if they do have an exposure. So we give them a 3-day supply of either raltegravir with intracidabine and TDF or raltegravir with lamivudine and zidovudine. So if you do have an exposure, you can get this supply from the ED, and then we can send a script to whatever pharmacy you have so you can get your full complete drug regimen for the 28 days. So this takes us into a little audience poll. So which of the following represent a complete HIV treatment regimen? I'll go through each one and I'll have you raise your hand for yes and then raise your hand for no. So the first one is bictegravir, tenofovir, alafenamide, and intracidabine. Raise your hand if you think this is a complete drug regimen. Okay, and then raise your hand if you don't think this is a complete drug regimen. All right, we got a smart group out here. Yes, this is a complete drug regimen. It contains our 2 NRTI backbone with our INSTI, the bictegravir. Our next regimen is darunavir, cobicistat, and intracidabine. Raise your hand if you do think this is a complete drug regimen. Okay, and then raise your hand if you don't think this is a complete drug regimen. Awesome, yeah. So that cobicistat component is really a pharmacokinetic boosting agent and is not classified as an active ART therapy, so we need 1 extra agent added on for this to be a complete regimen. Our next one is going to be abacavir, lamivudine, and dolutegravir. Raise your hand if you do think this is a complete drug regimen. Okay, and then raise your hand if you don't think this is a complete drug regimen. You guys are, what, 3 for 3. We've got yes, so this is our complete regimen. This is our Triumec. Our next one is going to be lamivudine and dolutegravir. Raise your hand if you do think this is a complete drug regimen. Okay, and then raise your hand if you don't think this is a complete drug regimen. So this one's kind of tricky. This is our 2-drug regimen that we talked about, Bravado. But yes, this is classified as a complete ART therapy. Okay, and then our last one, this one might be a little tricky, our intracidabine and tenofovir disoproxil fumarate. Raise your hand if you do think this is a complete drug regimen. Okay, and then raise your hand if you don't think this is a complete drug regimen. Correct, so this is going to be our PrEP product, so our Truvada. So this is not going to be used for patients with active HIV infection that are HIV positive. Okay, moving into how we restart ART therapy in our patients here at U of L. So all ART regimens are considered formulary products, which means that we can acquire them if we need to, but it's really going to be dependent on what we actually have stocked currently in our inpatient pharmacy or ACV pharmacy. When reinitiating ART, it's important that we try to minimize the duration that we're holding the ART therapy for the shortest amount of time as possible so that we can prevent any types of resistance or we can help suppress that viral load. We should make sure to perform a thorough medication reconciliation to make sure that we have all components of the ART therapy regimen, and then ensure that we're always restarting a complete drug therapy. So all components of the product so we don't have any resistance that can occur if we only start one portion of the regimen. And then we should always consider drug-drug interactions when we're reinitiating. So some common scenarios that have come up as I've been here at U of L and how to move forward with these. So one patient scenario that I've seen typically is patients that are unable to take oral medication. So what do you do in those patients? Well, some ART regimens can actually be crushed or come in liquid formulations, so you can work with your pharmacist to identify if their ART therapy does come in a liquid or can be crushed. But if not, like I said previously, you'll just want to hold all components of their regimen until they can swallow. For patients that come in experiencing a life-threatening severe reaction or toxicity to ART therapy, we'll want to discontinue all components of their regimen and then reach out to their outpatient provider like the 550 clinic for help on how to proceed forward or our infectious disease team. And then what do you do if U of L doesn't currently have the patient's ART regimen that they were on at home? So we have a few different options. You can first, if we don't have it in the inpatient pharmacy, we can ask our outpatient ACV pharmacy if they have it in stock and we can borrow it from them. If they don't have it, like if it's a more niche regimen, then the patient can bring in their supply from home and we can store it here and then give it to the patient. And then if not, if they're expected to be admitted for a long period of time, you can work with your pharmacist to potentially have us order it, but it will take a few days. In this slide, I really wanted to highlight all of the different barriers to ART adherence that we can see in our patient. So adherence is going to be the most important thing for allowing our patients to be virologically suppressed and help increase their CD4 count. As you can see, these patients face a lot of different barriers to taking their medication, such as cost, inadequate access to our healthcare providers, a lack of understanding of their regimen or their disease state as a whole. They may also need more social support, like they haven't fully accepted their diagnosis and their status, and they're not willing to tell people around them. So these are important things for you guys to help with whenever you see these patients be admitted. It's important to identify these barriers on why they're not taking their ART therapy and try to help resolve some of these issues. We do have some resources here at U of L. So one of our biggest one is going to be our outpatient 550 clinic. So this is called the Ryan White program. And one interesting thing is that there was a study that found that patients participating in the Ryan White program actually had a much higher rate of being virologically suppressed, so about 87.1% were virologically suppressed. So if we can get these patients in the 550 clinic, it's going to be really helpful for helping to control their HIV. I listed the front desk number and the new patient intake number for you all in case you have a patient that's diagnosed here and they need to be seen in the 550 clinic. You can also call the front desk if you have questions for their pharmacist or talk with your pharmacist to speak with them as well. And then some common places where these patients may get their medication. So one really cool program is the Kentucky AIDS Drug Assistance Program, or KDAP. This is a resource out of Lexington, Kentucky, where it'll help the patients get their ART therapy free of charge or at a discounted rate and help with any insurance issues that may come up. And then they'll just mail the medication directly to their house, or they can have it mailed to the clinic if the patient doesn't have like a stable home. And then you can also see patients get their ART therapy from the U of L specialty pharmacy. So these are just two pharmacies that you may see their medications coming from and resources to help them. Okay, I know that was a very broad topic. I tried to condense and make it more of an overview, but now we will move into our opportunistic infection prophylaxis. So as you can see from the slide, there are many different opportunistic infections that our patients with HIV are at risk for. So the ones denoted with the syringes are opportunistic infections that we can prevent by vaccination, like our human papillomavirus, our hepatitis A or B, and influenza. And then the ones with the pill bottles are going to be ones that we can prophylax or treat. Before we move into all the different opportunistic infections, I did briefly want to touch on IRIS, which stands for Immune Reconstitution Inflammatory Syndrome. So this is defined as a collection of inflammatory disorders that's associated with paradoxical worsening of a pre-existing infection once we start ART therapy. So in layman's terms, it can be an opportunistic infection that presents itself once the patient started on ART therapy and their immune system starts to improve. Then we can kind of unveil some of these opportunistic infections. This typically can happen about in 1 month to a few months following ART initiation, which follows kind of how our CD4 count responds. So it typically takes a few months for our CD4 count to really respond and our viral load to become suppressed. For management of this, it's really going to be dependent on what opportunistic infection they have. So I will refer you to the DHHS website and the guidelines because it's going to depend on which opportunistic infection they have on whether we can continue the ART therapy while we're treating it or if we need to hold it until the infection is resolved. One thing to remember is that IRIS doesn't represent treatment failure, so we can still put these patients back on that regimen once their infection's been resolved. Moving into our opportunistic infection, our first one's going to be pneumocystitis jirovecii pneumonia, or PCP, or some people call it PJP. It is a ubiquitous fungus that occurred in about 70 to 80% of patients with AIDS before the widespread use of ART therapy and opportunistic infection prophylaxis. It was associated with about a 20 to 40% mortality rate. However, now that we have suppressive ART therapy and we have prophylaxis, we've seen the incidence really decrease to less than 1 case per 100 person years. When figuring out which patients require primary prophylaxis against PCP, this is going to be dependent on their CD4 count or cell percentage. So if a patient has a CD4 count less than 200 or a CD4 cell percentage less than 14, they are indicated for PCP prophylaxis. And then there is a more niche population where we could consider PCP prophylaxis, and that's in patients where ART therapy cannot immediately be obtained or it has to be delayed and their CD4 count is less than 250. Then we can consider starting PCP prophylaxis in these patients as well. Our preferred regimen is going to be our trimethoprim sulfamethoxazole or a Bactrim 1 double-strength tablet daily. Some alternative regimens for our Bactrim can be 1 single-strength tablet daily or 1 double-strength tablet 3 times weekly. This could be particularly helpful in our patients with renal impairment, so a creatinine clearance less than 30, where they recommend reducing the dose by 50%. So if we moved our preferred treatment regimen from 1 double-strength tablet daily to 1 single-strength tablet daily, then we could make that dose adjustment. Our other alternative options, these are really reserved for patients who can't tolerate Bactrim or have a sulfa allergy. So our options are going to be dapsone plus pyrimethamine, leucovorin. So that's typically going to be used for patients that need both coverage for PCP and toxoplasma, which we'll get into later. We also have aerosolized pentamidine. This agent's very expensive and is associated with a lower efficacy rate and requires a specialized device to be able to use, so you typically don't use the aerosolized pentamidine. And then we also have atovaquone. Atovaquone is associated with more adverse effects, and it's a lot more expensive, and the patients typically don't like taking it because it's like this light yellow color and doesn't taste very good, but it is available and could be used if a patient can't take Bactrim or they can't take dapsone. So moving into kind of our second line agent that we typically think about after Bactrim, this is going to be dapsone. Its dosing is 100 milligrams per day or 50 milligrams twice a day. The main adverse effects to think about are going to be mainly blood dyscrasias that you can see, particularly hemolytic anemia, neutropenia, methaglobinemia, or agranulocytosis. This is typically more common in patients that have a G6PD deficiency, so it's important that before you use dapsone, you test patients for G6PD deficiency to avoid any of these blood dyscrasias. And then you can also see some hepatotoxicity and delayed hypersensitivity reactions. So after we've had a patient on PCP prophylaxis, when can we take them off? They're on ART therapy, they're virologically suppressed, and they have a recovery in their CD4 count. So we're waiting on their CD4 count to reach at least 200 for 3 months before we can stop our PCP prophylaxis. There is a special patient population where it can take a little bit longer for their CD4 count to recover. So if a patient starts with a very low CD4 count, it can take months or even years for them to recover with their CD4 count. So the guidelines do recommend that you can consider stopping prophylaxis if their CD4 count is between 100 to 200 and their viral load remains undetectable for at least 3 to 6 months. But typically this is going to be a situation more in the outpatient setting where they've been able to follow the patient for a very long time and make sure that they're virologically suppressed for that 3 to 6 month period. Moving into our second opportunistic infection prophylaxis, our Toxoplasma gondii encephalitis. So this is a protozoan. It's pretty rare in patients with a CD4 count over 200, with the greatest risk being in those with a CD4 count less than 50. Our indication for our primary prophylaxis in these patients are for Toxoplasma seropositive patients. So they have to be seropositive to really be at risk for this Toxoplasma with a CD4 count of less than 100. Good news for our patients is that the preferred treatment regimen for Toxoplasma is still Bactrim. So our trimethoprim sulfamethoxazole, 1 double-strength tablet daily, and then we can also consider our alternatives. So this makes it really easy for a patient that has a CD4 count less than 100. They're going to be indicated for PCP prophylaxis and Toxoplasma prophylaxis, so you're just not killing 2 birds with 1 stone. For all our alternatives, so we can't use dapsone alone to help prevent Toxoplasma, so we will need to use this combination dapsone, pyrimethamine, and leucovorin combination, or atovaquone. So these are our 2 that could be used to treat or prophylax against PCP and Toxoplasma, or you could consider atovaquone with pyrimethamine and leucovorin as well. For our indication for discontinuing our Toxoplasma prophylaxis, this is going to be for patients with a CD4 count over 200 for at least 3 months, and then again in those patients that have a little bit of a delayed time for their CD4 count to recover, you could consider discontinuing if their CD4 is between 100 to 200 for at least 3 to 6 months. Moving into our last opportunistic infection that we'll be discussing today, our MAC or Mycobacterium avium complex. This is a ubiquitous organism of the Mycobacterium avium subspecies. It occurs in about 20 to 40% of people with HIV that have advanced immunosuppression, particularly a CD4 count less than 50. So I did want to take another quick audience poll, so I gave you guys a case. So JK is a 25-year-old male who's admitted to green medicine for community-acquired pneumonia. he states that he was recently diagnosed with HIV and started on ART therapy with Biktarvy around 2 weeks ago. Labs from this admission show a CD4 cell count of 40. Would you start MAC prophylaxis in this patient? Raise your hand for yes. Okay, and then raise your hand for no. All right, so this is kind of a tricky one. I tripped you guys up with this one. But the answer is no, because the patient's on fully suppressive ART therapy with Biktarvy. So really our only indication for using MAC prophylaxis is in our patients that are not on ART therapy and fully suppressive therapy, so a 3-drug regimen, and they have a CD4 count of less than 50. So guidelines now recommending not using MAC prophylaxis in our patients with a CD4 count of less than 50 if we can either start ART therapy immediately or if they're already on ART therapy. And we'll get into the studies that found that the risk of MAC in these patients wasn't as high as we previously thought. So for Yanko and colleagues, this is our first study that looked at if we need to prophylax for MAC in patients with a CD4 count of less than 50. So they looked to determine if it's necessary for patients with a CD4 count less than 40 on ART therapy to have prophylaxis. So it included about 370 patients. They couldn't have any prior MAC infection, and they had to have a CD4 count less than 50 and be on combination ART therapy. Typically, the average patient in this study was a 40-year-old male with an HIV viral load of over 10,000, so they weren't virologically suppressed already, many of them. And they compared prophylaxis to no prophylaxis and found that the overall incidence of MAC disease was very low, 0.6 per 100 person months. So it really wasn't as high as we previously thought, and that no MAC occurred among patients on ART therapy who were virologically suppressed at baseline. Our second study is by Jung and colleagues, and it looked to compare the incidence of disseminated MAC in patients receiving prophylaxis versus those without prophylaxis when they had a CD4 count less than 50. This was a little bit of a smaller study with about 150 patients. And the average patient was a 38-year-old male with a CD4 count of 20, so pretty low. And they found no difference in the proportion of patients who reached a CD4 count over 100 or those that were able to achieve viral suppression within 12 months. So really no effect on our efficacy if you gave them prophylaxis or not. And then they found no difference in the incidence of MAC between the groups. So following the publishment of both of these studies, the guidelines then updated to reflect that patients that are on ART therapy with a CD4 count less than 50 don't need MAC prophylaxis. So if a patient cannot be started on ART therapy and they do have a CD4 count less than 50 and are therefore indicated for the prophylaxis, we could recommend giving azithromycin, clarithromycin, or azithromycin twice weekly or once weekly. And then we should discontinue primary prophylaxis once that patient started on ART therapy. All right, so this is just a brief summary of what we talked about, our opportunistic infections, and where you give prophylaxis based off their CD4 count. So less than 200, but over 100, they'll need PCP prophylaxis, typically with trimethoprim sulfamethoxazole. And then if their CD4 count's less than 100, we can give toxoplasma prophylaxis in patients that are seropositive. And then again, in patients with a CD4 count less than 50, MAC prophylaxis is now not indicated if they're on fully suppressive ART therapy. Moving into how we can prevent some opportunistic infections, so through vaccinations. So the CDC website has a great resource for this, and then also the hivinfo.nih.gov also has a good resource for determining if patients can get vaccinations or not. We're really going to be mostly concerned for giving our live vaccinations, so our MMR and our varicella in patients that are immunosuppressed, so they have a CD4 count less than 200. Those two vaccinations are going to be contraindicated in that patient population. But most of our other vaccinations can be given for most of our patients with HIV, regardless of their CD4 count. If a patient is indicated for our MMR and varicella, once their CD4 count recovers, you could consider giving them these vaccinations at that point. And then for our COVID vaccine recommendations, so this is going to be similar to our other moderately or severely immunosuppressed patients. So they're indicated for 4 total doses right now, with the third dose being given at least 4 weeks after the second dose, and the fourth dose at least 2 months after the third dose or their most recent booster. Okay, and then this is just a quick summary slide. These patients require a well-rounded care and need a lot of different help as far as healthcare access, medication affordability, and just social support as a whole. So I thought this graphic kind of summarized all the different parts that you need to consider when you're taking care of a patient with HIV. So we need to consider their medication adherence and how we can help them be more adherent, how their social support is and how we can help them from those aspects, access to care, making sure that they have follow-up in an outpatient clinic or with the 550 clinic, and then making sure that we can help with medication availability, which they can help with that in the 550 clinic as well, and then making sure these patients are educated and we provide them with appropriate opportunistic infection prophylaxis when it's indicated. All right, and that concludes my presentation. At this time, I'll take any questions you guys have.